Oh, good afternoon, everyone, and welcome to the COVID-19 vaccine update state of play presentation that's being facilitated today by the Hunter New England Central Coast Primary Health Network and our colleagues from Central Coast Local Health District. So I'd like to begin by acknowledging that wherever we are today, we're meeting on Aboriginal land across this broad but beautiful region, and acknowledge elders past and present. Today we've got quite a lot of you online. We will be taking questions via the questions panel which you should be able to see on your screen. So we will leave some time at the end of this fairly brief presentation for questions. So we really encourage you to take the opportunity to ask questions and we'll do our very best to respond to them. So our presenters today will be Dr. Catherine Taylor, who's the Director of Public Health at Central Coast Local Health District. We will soon be joined by Georgina Rossi, one of her colleagues from the Central Coast Local Health District, and Kimberly Booth, who's the vaccine coordinator, I think, for the Primary Health Network. And I will also be online. I should have started by introducing myself. My name's Catherine Turner. I'm the Exec Manager for Commissioning here at the Primary Health Network and currently leading the COVID response at the moment. So without further ado, Kat, I'll hand over to you. Thanks.
Thank you, Catherine. And having done that, I have just momentarily lost the ability to share my screen. Okay, I think I've got it. Can you see that?
Yep, we do.
Okay,
yeah, we
beautiful.
can see the screen.
Okay, so thanks everyone for your time at this very busy and exhausting time of the outbreak. So I too would like to acknowledge the traditional owners of the land that we're meeting on, and also particularly devastated that NAIDOC Day has been yet again disrupted by this pandemic. So yeah, my thoughts with all of our Aboriginal colleagues and community. So we thought it would be timely to give an update. Everything's been moving very quickly, as you can imagine, and what a lot can change in just a fortnight. I was reflecting earlier that, you know, on the 16th of June, I was sitting down in Sydney at a meeting of the Health Protection Leadership Team. We were talking about an exit strategy for COVID, and then at about 2 o'clock, Vicky Shepherd, the Director of South East Sydney Local Health District, said, oh, just so everyone knows, I've got a new case and it's in a limo driver. And that's where it all began. So just a quick recap, obviously, of the epidemiology of COVID in New South Wales to date. We're all quite familiar with the sort of overseas first wave, largely cruise ship acquired, and then household contacts of those international returnees, which happened kind of around March of last year. Subsequently, the so-called second wave, which kicked off in Victoria, but then seeded across via the Crossroads Hotel into New South Wales, and was quite a prolonged outbreak around this time last year. And certainly some confusion in the media when, you know, Crossroads was again mentioned, but now it's actually Crossways Hotel in Strathfield that's implicated as a venue. Anyway, and then we're also all familiar with the Northern Beaches outbreak, which occurred over sort of the Christmas New Year period. And then it was very quiet in terms of locally acquired activity. There was the odd case in hotel quarantine, but you know, by and large, there was an increase in international returning cases in accordance with the global epidemiology of the disease, especially, you know, the worsening situation over in India back in sort of March, April, May this year. And that brings us to where we are now, with quite a steep and exponential rise in cases in New South Wales, again, just in the past 2 weeks of locally acquired cases. I won't dwell on that slide, but just to give you the update as of the cutoff 8 p.m. last night, we have 175 cases in that so-called Bondi cluster, of which 14 are unlinked, and it's not quite as bad as 14 unlinked, but there are 5 unlinked and then 9 close contacts of those people, and a further 7 that were under investigation last night. So it's quite a concerning situation. There have been several super spreading events. We've all heard about this birthday party in West Hoxton, which it sounds like went off from many different perspectives. And unfortunately, you know, we have also heard about other exposures in vulnerable settings, most recently, for example, in Fairfield Hospital and in Royal North Shore Hospital just over the past 24 hours. There are over 230 exposure locations, so it's quite an unwieldy list that's on the New South Wales Case Alerts website. So really critical for people to keep checking that website regularly because things change several times a day. And we now have over 5,000 close contacts in quarantine in association with this outbreak. So a huge effort of public health and the contact tracing network across New South Wales Health. All of the public health units have pitched in and surged up, as well as the Central Ministry of Health, to try and get ahead of this outbreak. This is the epidemic curve of this cluster. And note that this is by onset date. So by onset date, it looks as though things are heading in the right direction, but unfortunately, some of the cases that we're picking up now, and we have found this is the case often with people who are, you know, these mystery or unlinked cases that think they don't have COVID, that people are being picked up who have had symptoms for potentially a week. So their onset date was earlier in the cluster, but the bad news about that is that obviously they've been not in isolation for that week whilst potentially infectious, and going about their usual business. And so it will be, you know, still some time before we see the so-called lockdown measures really have an effect. And unfortunately, you know, as events continue to generate other sort of seeding events, there's always the potential for things to take off again. So, we do remain really on that knife's edge. So what is behind this outbreak? We have heard about this Delta strain, which is certainly the dominant strain, which has really risen to global prominence across the world. And really just to emphasize that, you know, these variants of concern, when they emerge, the rapidity with which they actually kind of overtake as the dominant type. So this is a little graphic from Eurosurveillance demonstrating sort of the proportion of whole genome sequences that have been taken up in different countries by the respective variants of concern. So the orange that you can see here that's sort of overtaken from the blue, that is the B117, now known as alpha strain, which was the strain first observed sort of in the UK and very quickly rose to prevalence there. And as you can see, also across other countries. And then here we also see the yellow, the Delta strain, and we see how rapidly that really sort of substituted for the majority of sequences in India, and also now is starting to account for the almost 100% of sequences done in the United Kingdom. So it obviously has some evolutionary advantages, which are enabling it to really take a foothold in communities, in particular with respect to its transmissibility. But we are also seeing, unfortunately, that it does appear to be associated with an increased severity, so about twice the risk of hospital admission with this Delta strain. This is a graphic taken from the same article in Eurosurveillance, which essentially just tries to give an estimate of the effective reproduction number. So we have heard of this idea of a reproduction number of, you know, how many new infections are generated by one infective case in a susceptible population. So for, you know, I guess garden variety COVID, we're thinking in the order of 2 to 3 new infections. Whereas with the Delta strain, it is looking sort of, you know, around double the infectiousness. So, you know, potentially up to as high as an R0 of 6 to 8. And so that's really concerning. And we also know that, you know, COVID is SARS-CoV-2 does not spread in you know, very homogeneous way. It's quite dispersed. And so, you know, it's not quite as predictable as, you know, 1 goes to 6 goes to etc. It's actually, you know, while 80% of people may only pass it on to 0 or 1 other people, there's a small sort of 20% of people that may sort of be involved in these super spreading events and result in quite substantial transmission events like we've seen in West Hoxton. But we are certainly observing with this particular outbreak quite a high attack rate amongst households, which is very concerning. So certainly increased transmissibility with this Delta strain, and thought to be related to the spike protein characteristics and the efficiency with which it attaches to ACE2 receptors. And so what that actually looks like, unfortunately, so this is some CCTV footage from Westfield Bondi Junction, which shows sort of the moment when transmission was thought to have occurred between some people there. You can see that the person circled in red is they're actually on their way up the escalators to see a movie. And these people circled in blue have had very fleeting contact walking past this person on their way to get a hot chocolate from Max Brenner's. So very, very concerning in terms of the types of transmission that we're witnessing with this outbreak. So what does this all mean? Basically, we need to work harder to achieve control. So certainly an increase in public health and social measures. So we've seen the aggressive strategy of restrictions on movement, basically stay-at-home orders, as well as the mandate for mask wearing, particularly in indoor settings. And the other side of that equation is that we need higher vaccination rates. So if you think about, the level of non-susceptibility that's needed to achieve herd immunity as being a function of the reproductive rate, so sort of the inverse of the reproductive rate, the higher the reproductive rate, the higher the proportion of the population you need to be not susceptible for the virus not to kind of find a path through. And similarly, there's the question in terms of vaccination effectiveness against variants. And so if vaccines are less effective against a particular strain, then obviously you need a higher vaccination rate to achieve the same effective rate of protection amongst the community. So, so it really presents a challenge for public health in terms of all of these things. So I'm sure we're all fairly familiar with the current restrictions. As you know, Central Coast has been lumped in with the Greater Sydney restrictions. I would say that to date, we have not had a case associated with this current outbreak on the Central Coast. We do have close contacts quarantining in our area. And somewhat hearteningly, we also have not seen a positive sewage detection in the Central Coast since December of last year. But having said that, that could change at any moment. And I, for one, am quite grateful that we are included in these restrictions just because of the amazing mobility of this virus with people as they move around. So I think it is really sensible that we're included in that. You may be familiar with the public health orders. So they pertain to mandatory mask wearing in non-residential indoor settings. As well as a requirement on people to stay at home unless for essential reasons. Now, some of you might note that health facilities are exempted from these orders, but the intention of that is that, that health facilities are actually covered by the so-called CEC risk dashboard and escalation framework for infection control. So currently, Central Coast, again, is included with Greater Sydney in being on red alert under the CEC transmission framework. So I've just popped in there a little summary of what red alert means for our health facilities. This is the New South Wales health facilities. Obviously, there's an escalation in PPE, universal mask use by healthcare workers, also by anybody presenting from the community, and visitors by exception. So I would encourage you in your practices as part of your COVID safety plans to be considering those strategies as well. So back to the question in terms of vaccine effectiveness against Delta variants. So there's actually been some quite heartening evidence coming to light recently. So Public Health England, you'll be aware that the UK has predominantly relied on the AstraZeneca vaccine for its rollout. And a recent analysis by Public Health England has shown that 2 doses of COVID-19 vaccines, both the Pfizer or the Oxford AstraZeneca, they're both highly effective against hospitalisation. So that's a really good news story. So the vaccination strategy in Australia has really been aimed at trying to prevent that severe end of disease and hospitalisation. So we know both vaccines are basically equivalently protective and highly protective against the Delta variant for hospitalisation. Now, the story does change slightly in terms of symptomatic disease, and there's always been a different sort of question in terms of how effective are the vaccines in preventing you catching the condition and displaying symptoms from the condition. So this is another study. This is a preprint using similar data, looking at the effectiveness of COVID-19 vaccines against the Delta variant. And I guess the key messages from this article were that both the AstraZeneca and the Pfizer were inadequately protective after a single dose. So the protection was basically 33-ish% from a single dose of either Astra or Pfizer, not a particularly significant difference. And even for the UK Alpha variant, still only kind of 50% from that single dose. And we can see also that for AstraZeneca with the second dose, the effectiveness rises to about 60% against Delta versus sort of 66.1% against the Alpha. And for Pfizer, it's thought to be around 88% effective against the Delta versus 93% against the Alpha. So this is for symptomatic disease caused by the Delta variant. So we can see that there is a slight drop in effectiveness for both vaccines against this particular variant when compared with the Alpha. But as I said, in terms of the high level protection from severe disease and hospitalization, equivalent and very protective between both vaccines. I'll just change course a little now and talk about thrombosis with thrombocytopenia syndrome. I'm sure this is something that you've all become very comfortable talking about in your practice. I'd also encourage you to follow the TGA weekly safety updates on COVID vaccination. So these tend to come out on a Thursday. And so I will say that this data here is about a week old now. So the one for today hasn't come out yet. But essentially, as of last Thursday, there were 64 confirmed cases of TTS in Australia, of which 2 were sadly fatal. But also, you know, as there's been conversations where we're starting to increase our recognition of this syndrome and notice the full spectrum of disease, from obviously the catastrophic to the more kind of garden variety clots, which are quite treatable and most people have recovered from that condition. And so our understanding of this condition is evolving all of the time. I was on an expert panel yesterday discussing a new suspected case, and what transpired from that discussion was, unfortunately, with many of these catastrophic type cases, many of the cases have actually had a several-day history of symptoms prior to presenting kind of in extremis, unfortunately, to tertiary medical systems. And so I think that really just brings home that requirement to educate the public, to speak to your patients very closely about the need to seek immediate medical attention if they have any of the red flag symptoms. So you could probably recite these in your sleep, but severe or persistent headache or blurred vision, shortness of breath, chest pain, leg swelling or persistent abdominal pain, and any unusual skin bruising or petechiae. Now, your average person probably won't know what petechiae are, so pinpoint round spots beyond the site of vaccination. So really, really critical that, you know, if people have a sore leg, don't ignore it, you know, go and get the appropriate investigation. So we've talked about the importance of an early full blood examination to look for platelets, because we're looking at thrombocytopenia, but also coagulation studies, so looking at fibrinogen and D-dimer. And, you know, even if the platelets are normal, if the D-dimer and fibrinogen are abnormal, then that would probably be a prompt to repeat the full blood examination again, to do serial FBEs to see whether there is any kind of downward trend in the platelets. So really important to kind of get these key messages to people that are having the AstraZeneca vaccine to get help if they experience any of these symptoms. And we're talking in that time period of about 4 to 30 days after vaccination. I won't spend much time talking about politicians giving medical advice, but this is just a bit of a breakdown of the estimated rate of TTS per 100,000 AstraZeneca vaccinations. And you can see there in the less than 50-year age group, we are talking about a rate of sort of 1 in 33,000. So I probably wouldn't be calling that extremely rare anymore. But also noting that, as you can see, there's about a 3% fatality rate out of the sort of 64 that we've had to date. And so I guess the chance of dying from TTS is much, much less than that. So just a few statistics for you to become comfortable with discussing with your patients. Some other evidence that has come out recently is around mixed dose schedules. So the eagerly awaited results of the COM-COV study, which was sort of comparing heterologous and homologous prime boost schedules with the AstraZeneca vaccine and the Pfizer vaccine. So they looked at both ways, Astra first followed by Pfizer and Pfizer first followed by Astra, and compared that with a homologous schedule of Astra and Astra. This was a non-inferiority study, and they were looking at basically safety and immunogenicity. So they weren't looking at kind of vaccine effectiveness in terms of clinical endpoints. They were looking at antibody titers. So anti-spike antibodies 20 days post the booster dose, sorry, should I say the second dose? And they did demonstrate non-inferiority with the going from AstraZeneca to Pfizer, but not with the Pfizer going to AstraZeneca. However, the concentration of anti-spike antibodies with both of those mixed schedules was actually higher than the homologous schedule of Astra with Astra. I guess accordingly, they also did notice a much higher rate of adverse and systemic effects with the mixed schedules. So, you know, just the kind of systemic local reactions. So nothing kind of serious, but just to be aware for the possibility of mixed dose schedules that they're quite reactogenic. So this evidence is currently under review by the ATAGI, and we don't yet have any indication from the Australian government in terms of the national position on mixed dose schedules. So I just thought I'd refresh the current ATAGI advice. Comirnaty, which is the Pfizer vaccine, is the preferred vaccine for those aged 16 to under 60. AstraZeneca can be used in adults under 60 for whom Comirnaty is not available, but that's quite an involved risk versus benefit discussion and informed decision making with the patient, and generally, you know, in quite a rare instance where, you know, where Pfizer is not available. People of any age without contraindications who've had their first dose of AstraZeneca without serious adverse events are also strongly recommended to receive that second dose to get the protection they need. And on the basis of current information, Comirnaty and AstraZeneca are not considered interchangeable. So I think Georgina is going to speak to the exemption, to the alternative vaccine access process. There's a form, and this is taken directly from the form. So it's a form that gets signed off by you as the patient's GP. And there's quite a narrow set of contraindications which would sort of fulfill the criteria for completing this form. And you can see here the listed contraindications. So CVST, past history, heparin-induced thrombocytopenia, idiopathic splanchnic venous thrombosis, antiphospholipid syndrome with thrombosis, anaphylaxis, thrombosis with thrombocytopenia, or another serious adverse event attributed to the first dose of AstraZeneca, a history of anaphylaxis to a component of AstraZeneca, or other medical contraindications. So you can see that the set of indications is quite narrow. So I'll wind it up there. Sorry, the time has flown. Just to say, look, this New South Wales outbreak, unfortunately, is far from over. 2 doses of a vaccine are recommended and required for that optimal protection. Just to really encourage you all with your pre-vaccination counselling, both doctors and nurses, that patients really need to have a high degree of vigilance for red flag symptoms following vaccination with AstraZeneca, and to seek medical attention if any develop. And also the importance of testing in all that have symptoms. So there's a lot of respiratory things circulating at the moment. And unfortunately, we're not in that privileged position where we can say, oh, it's not COVID. So, and then lastly, just to tell you all to look after yourself. We're all exhausted, and it's been, you know, a pretty massive 18 months and pretty demoralizing with all of the changes and politicking that's going on. So please do take care. Okay.
Thanks, Kat. There's quite a lot of questions, but we'll go to Georgina first, and then we'll come back, and you might have a chance to review some of those questions while Georgina speaks. So Georgina, over to you. Hello.
Everyone, I'm Georgina Rosie. I'm the manager, the operations manager for the Central Coast Local Health District's COVID vaccination program. So I'm just going to briefly discuss today the program, where we are to date, and hopefully you can see my screen, where we are up to today in terms of our program across the Central Coast, and be able, as Kat indicated, just give you some information about the medical request for alternative vaccine. So this information is just screenshots of what has been distributed via the PHN on Monday afternoon, evening, and so hopefully you would have received that, and if not, I'm aware that it is being put up onto Health Pathways today, but it's also available by contacting the Central Coast Primary Health Network. And this is a Central Coast Local Health District process. So the documents that you'll see are a statewide documents and requirements, but every LHD runs their vaccination program slightly differently. So what I'm going to talk to today is how we, as a Central Coast LHD, will be processing and assisting with you in processing those requests for an alternative vaccine. So in this case, Pfizer. So the forms are the same, and but the process may change in the Hunter if you have to deal with a Hunter program. So this is just some screenshots of what was sent out to you as GPs or specialists on Monday. And it's just to give you some instructions in a nice simple form and some links and email addresses and things like that. So you have everything that you need to be able to process this request. So in a nutshell, what we're talking about is those patients that are coming to you saying that they don't want AstraZeneca and they would prefer Pfizer. And it's been very difficult because there's, as Kat has attested to, what is out there in the media and understanding around risks has made some confusion for patients, so they're quite anxious around what vaccine they receive. So the state has come up with a consistent approach across the state for processing those requests. So the language is not that they're asking for an exemption from AstraZeneca, it's that they are requesting an alternative vaccine. So at the moment, that's Pfizer. So that's the language that we're essentially using, is a request for an alternative vaccine. So essentially what's the process is, and I'll show you the forms in a moment, is that you as the GP or specialist would complete the recommendation to receive Pfizer vaccine form, and that you or the patient needs to email that form to us, and there's an email address there. And then one of my staff will contact the person directly and make an appointment and facilitate an appointment at either Wyong or Gosford clinics. The reason for that is that we do not do walk-ins. They need to be booked in. And also in some cases, these clients sometimes need assistance in terms of facilitating the IT systems and the registration processes to be able to access the clinics. So my staff will contact them and make a booking. So the state requires the form to be brought with them to the appointment and to be included in the medical record, because it is essentially a deviation from the recommendations for that vaccine. So it is critical that the people are informed that they need to bring that piece of paper with them, but it does need to be emailed through to our clinic so we can initiate an appointment. And as I've said there, the bookings are essential. We do not accept people walking up with the form. The other thing to note is that the form is, this is the form. The form is the critical part. We cannot accept a letter from a doctor or specialist, and we're not able to accept a medical certificate or anything other than this form. So for those people that have already contacted us or supplied us with a medical certificate or a letter from you as their GP, we have responded to their emails and provided them with this form and the covering letter, which you'll see in a moment. and explain to them that they need to bring, get this form filled out. So that is the critical message here, that this form is the only way to be able to request to receive an alternative vaccine. And as I've said, that this process is the form that is consistent across the state, but this is the process that we'll talk about is just a Central Coast process. So this is the form. It needs to be filled out and obviously signed with all of the related information based on the medical practitioner. And then also you just need to indicate what is the reason for requesting the to receive Pfizer. This is the letter which was also sent out. It's just designed as a flyer or some information sheet that you can provide to your patient at the time of having the discussion. And this is a state template, which we've just added our contact details. And we've also added, for their benefit and yours, some links to information that is referred to in this information sheet. So that can just get printed off at a clinic level, and you can provide that information sheet to your patient at the time of having that discussion, and it just goes through, as Kat referred to, all of the information, so they're making an informed decision around which vaccine they should be receiving and what the exemption process or the request to receive an alternative vaccine, what that process would entail. And it also just steps them through there around and a reminder around what needs to happen with the form. So that's that. And just in a summary, I just wanted to give you an update on the program rollout on the Central Coast. There's been lots of change in the last couple of weeks in particular, and there's another expected change in the next 2 weeks. So as we stand at the moment, the Gosford-based clinics are open Monday to Saturdays, and it's a Pfizer-only clinic, and it's extended hours. So on Monday to Friday, it's 7 till 6:30, sorry, and Saturdays is 7:30 till 4. And at Wyong, it's Monday to Saturday. We're doing AstraZeneca on 2 days of the week and Pfizer for 4 days. So Monday, Tuesday is AstraZeneca and Pfizer is Wednesday through to Saturday. And the Wyong program at the moment is 6 a.m. till 12 midday, but in the beginning of August, we will be running extended hours, the same as Gosford, for the Wyong program, because we'll be moving into a new venue. And so at the moment, we are consistently immunising around 2,500 to 3,000 people a week. And then in 2 weeks' time, we will be significantly increasing our Gosford clinic. And by August, when the Wyong clinic comes online, we will be able to immunise between 7,000 and 8,000 people a week. So it's a significant program, and it's been extremely well received by the community. So we're now booking, bookings are approximately 60 days, so about 2 months, 2.5 months away. So yes. So the other thing I just wanted to talk about is how to access the clinic. So the key is around, now there is just the one eligibility checker link, which is the federal government's link that everyone can go through. Now, unfortunately, the reason, and that's one of the reasons why we need to receive that email, that form emailed, because your patients will not be able to progress through that standard checker registration process because they'll be deemed ineligible. So we need to provide them with a separate link just for them to use to be able to access the program. And that's the same with your staff and have GP practices and household contacts. So if there are, we've been communicating extensively through the PHN to ensure rapid access for you as GPs and your staff, as well as household contacts. but if there are still staff out there that haven't been vaccinated, you can certainly contact us via that COVAX Hub email address, and we'll be able to provide you with the direct link, particularly if staff are outside the eligibility age for Pfizer and that they are requesting Pfizer. And where possible, the household contacts the age criteria applies through the program. So that's all I have. I'm expecting more questions, but that's essentially the details of the program and the long-awaited medical pathway for accessing Pfizer for your clients.
Thanks, thanks, Georgina. And there is such a lot of information, and you're obviously super busy rolling out this program. I will just pass on a little bit of information from the Hunter New England team. The information's very similar. How you access that form is via Health Pathways, where the form is. It's a very similar process. But there's a different email address, obviously. There's a different process also for aged care staff, and I know Lynn has been doing some work with our team on residential aged care staff and prioritising and how we're going to assist them all to be prioritised as well. So that's still a work in progress. So yes, and the very important message from the John Hunter Hub, please do not rock up with that form in hand, because they've had been turning people away and people get aggressive. So we really need to explain to people that that's just not something they can do. All right, now there's a lot of questions. Kat, can you see the questions?
I don't think I can. I can see some things, but maybe not everything. But I'm willing to stay for another few minutes to, yep.
If you could, yeah. Some of them are quite specific. So there's some quite a few questions about TTS. So if someone has a specific question about this, for example, what if a 30-year-old with a high-risk medical condition is due for their second dose of AstraZeneca? Do we encourage them to go ahead or wait for Pfizer, therefore mixing their schedules? So I know you probably don't want to respond clinically to that. Is there a place where people can go and get that information? Or you can respond.
Yeah, look, certainly. Yeah, I can give general principles. So I suppose the question is, what is the high risk medical condition? So generally the advice is people who safely had the first dose of the AstraZeneca are recommended to receive the second. And so that's on the basis that TTS with the second dose is much, much less common. So it's thought to be more like 1 in sort of a couple of million. And again, we've talked about that spectrum of sort of fatality and non-serious disease. So yeah, so the advice is that in general, people who've had the first dose without issue should go on to have the second.
Okay, there's a couple of public health measure questions. So one is, you talked about the red alert level on the Central Coast. So is that the same in Hunter New England, and should practices follow the same principle? And following on from that,
so it's not.
Okay,
yes.
so it's, and then do we need to check temperatures on all patients in the New England for general practice?
So my understanding is that Hunter New England is on Amber Plus. Yep. So it's sort of a slightly less stringent requirement, but also with everybody in masks. So I mean, I guess it's similar. It's pretty similar in effect to Red Alert. And I'd suggest that degree of caution. In terms of temperature screening, we've talked about that at previous webinars, and I guess the sensitivity and specificity of it is pretty poor. But it's really critical to ask those epi questions in terms of, you know, do people have symptoms? Have they been to any known exposure locations, etc., when you're trying to do your triaging and risk assessment?
And if someone has been to a hotspot area, so for example, if someone's been to Sydney and returned, worked at a hospital, so if a healthcare worker has been to Sydney last weekend and returned to regional New South Wales, are they under the same stay-at-home orders as if they were in Sydney? And what's the impact of that on essential workforce?
So at the moment, the current current public health orders are just for stay at home. So work is one of the reasonable excuses to leave your home. So I guess the orders are permissive in that regard, but anyone who's been in the Greater Sydney region since the 21st, which was last Monday, is under those same requirements.
Okay, well, hopefully that answers that question for people. Is there a waiver that patients need to fill in? Oh, this is about the indemnity that's been announced, but I'm not sure there's a lot of detail about yet for GPs if they wish to, if they and the patient wish to proceed with AstraZeneca first doses.
Yeah, I'm afraid I can't speak to that.
No, we're waiting on final information or clearer information. I know when we met with the department on Tuesday, they were still busily trying to sort that out. So at that stage, that's not the case.
Catherine, can I just speak to that very quickly? Sorry, it's Georgina.
Yeah, thanks, Georgina.
We've had a meeting with the state today, and they've clarified that until further notice, the state-run programs will not be issuing immunising AstraZeneca for people 59 and under. So at the moment, New South Wales Health is saying that they are sticking to the 60 and over for AstraZeneca. So that's just a side issue that even if someone does walk into our clinics today, state-run clinics are not permitted to immunise anyone under 59 with AstraZeneca.
Okay, thank you. And Kat, here's another question, or you or Georgina might know. There's been some increasing information coming out of Europe about increased risk of myocarditis, pericarditis within young male population after the first Pfizer dose. Have we seen any of this in Australia that you know of?
It's certainly an adverse event of special interest, and certainly if you just review those TGA weekly safety updates, they do kind of keep a watching brief on that. So it's not yet kind of been added as a, something that you would put into your consent process or anything like that, but certainly there is emerging evidence in that space.
Okay, and we do have those links on Health Pathways as well for people. So we do have a team of people checking that information and trying to distill it for people as we go. Now, there's a comment here from Nicola about RACGP and the privacy standards suggest not to email clinical information. I know that's something that it's quite a problem. But you're asking for clinical information to be put on that request. So obviously it's a statewide process. Georgina, it's probably a question for you. Should we ask the Emergency Operations Centre about that?
Look, it is. I'm happy to take that back and feedback through this group. But it is a statewide process, and the majority of LHDs are requiring that form to be emailed to the clinic prior to attendance. So I will take that back to SHEOC and just make sure that we get a statement around that requirement. But yeah, so I don't have an answer to that other than that was the recommended state's approach to this pathway. So, and they're certainly emailing things to us. So leave it with me and I'll come back with some further information.
Thank you. And I think that's why there is still faxes in use. It's really related to that. There's another specific question. I think you might have answered this, Kat, but so if a GP works in rural New South Wales but lives in Greater Sydney, he is an essential worker, should he continue to travel to work in rural New South Wales from Greater Sydney? How does the health
I suppose the general advice, yeah, we are really trying to encourage people to minimise movement as much as possible, and I'm not sure there may be a strengthening of the order over the coming days in terms of trying to limit that movement, but under the current orders, yes, that person is permitted to travel for the purpose of attending work, but they need to go directly to their place of work and not kind of deviate from the orders, like just go directly to work and then return sort of thing. Not kind of go there and be out in the community.
Okay, well, hopefully that answers that question. The next one I can answer. So it's about GPs across the region being notified of when they will commence receiving the Pfizer vaccine. Kimberly, my understanding is that GPs in groups 1, 2 and 3 have been notified that when that will commence. Some practices will commence next week and should have been started receiving their supplies already, but this is being handled by the Commonwealth, so that's about all we can say to that. And we can't provide information about which of those practices is commencing that at this stage. So sorry to be a bit obtuse there with that one. There's some other questions. The process for getting household contacts of healthcare staff vaccinated in the HNE region. We will follow that one up, Zinni, and get some information out. I know there is a process, so I will find out what that is. And we're also looking at extended clinics. We were notified today about specific clinics for aged care workers at John Hunter and in other parts of the Hunter New England region, and we're working with the Central Coast team on how we can provide some special clinics for residential aged care workers and I imagine and GPs and practice staff and other people as well. And Georgina has already spoken to that. Where can we access the
Catherine,
recommendation? Yes, go.
Oh, sorry. I was just going to say, I spoke to the Hunter people today at our state meeting, and they've confirmed a similar barrier to household contacts using the link, the standardised link. So they are doing what we're doing, and that is you contact the clinic directly, and they will talk you through or either provide you with a link for household contacts or talk you through the process, so which is similar to us.
Okay, so we'll get that information sent out. Jenny, we might see if we can send some of these things out after this directly to all of the participants. If someone was after some information for the fatality rates for TTS across the various age groups, Kat, I imagine that's in that update information that you were talking about that comes out weekly?
I don't think that it is, but yeah, I think it was a 48-year-old person and a 52-year-old person from memory in the two that we've had so far.
Great. And as you say, it's a small number, so it's a bit difficult yet. Look, I think they're probably all of the questions that we can answer today. So Kat, Georgina or Kim, was there anything that we've missed in passing on in terms of information? No?
Just sorry, I did forget to mention about sorry, it's a bit of a delay. Sorry, Catherine. I forgot to mention that we have been prioritising the staff of residential aged care facilities and disability providers. So if the GPs do have people coming in that are requesting that and they're in that workforce, they can go, the PHN's got that information, as well as all of the providers have been sent the specialised link for their staff on this is the Central Coast. So just encourage them to go back to their provider, to their employer, or otherwise I'm happy for them to be provided with our generic email and we can then contact them individually. So we've immunised many hundreds of our residential aged care staff, and most of our facilities now have engaged in that program. So, but that's the process on the coast.
Thank you. And just probably make it easier if anybody needs access to that sort of information, if they email vaccine@thephn.com.au, that's probably easier to remember. And Kimberly or I'll make sure that we get the relevant links out to everybody. It's probably the easiest. All right. Well, with that in mind, I'm going to thank everyone for their time. I know everyone's super busy, and I really want to echo what Kat was saying about this. Seems like we're right back where we started in some ways. So I myself am at home waiting for my COVID results from yesterday. So we are back where we started. But look, I want to thank Kat and Georgina for their time this afternoon in answering all those questions, and all of you for all the work that you're continuing to do across the region. You know, it is absolutely exhausting, and I hope you are looking after yourselves and doing whatever you can, and we'll continue to provide information like this. So an evaluation form will come up at the end of this. If there's some other specific topics you'd like covered, or information or questions or other evaluation comments that you want to add, please throw those in there, and Jenny and the team from the education team will be able to provide those back to us. So thanks again. I hope everyone is staying warm today and has a good day, and hopefully some of that information has helped you out with some of your questions. So thanks very much.